Okay, everyone. Well, welcome to the session today. We are recording this session. I know that I have several folks, both clients and some of my billers who can't make it today, so I'm going ahead and recording this. I have everyone on mute just because of background noise. This way we don't have a lot of static on the line or reverberation. There will be a point in time at the end of the meeting today where I will be opening it up for questions and I'll bring everyone off of mute. However, if you're not speaking, you may want to just mute yourselves individually. Again, just for background noise, if we have 20 people on the call and everybody's got TVs going or phones ringing, whatever, it can be very distracting when we're trying to have a discussion over this webinar format. So I'm glad those of you who are here could make it. This is a very important session today because we're actually going to be going into the meat and potatoes of the ICD10 coding. Now I know we're not going to be able to cover everything in the hour that we have, and I will be available for additional questions as an ongoing basis, throughout this entire process, as are your billers. But what I wanted to do today, my objective is to make sure that everyone who is on this call and everyone who listens to this call knows how to take their favorite ICD-9 codes and convert them to ICD-10 so that you can begin to develop what we call a hit list or a top 25, top 50 favorite codes that you will be using for ICD-10. There are some important things, though, before we actually get into the mapping over of the codes that you need to know. And so I wanted to go over some of these conventions with you. And let me see if I can get there we go. So let's talk about some basic coding rules. I'm going to try to move this. I don't think I can, but it only cuts off a little bit of the top of it. So the basic coding rules are very similar to the coding rules of ICD-9. The thing about ICD-9 that's different than ICD-10 is that in ICD-9, a lot of the codes, even the most specific codes in ICD-9, were fairly non-specific. And I used last week, if you were in class, I used sciatica as an example. In ICD-9, we have one code for sciatica. And so if a patient has sciatica, that's what you coded. It was very non-specific. But in ICD-10, that code now is 6 codes. So you have to know the most specific code for that patient's condition. And so the main thing to know about coding to the highest level of specificity is if you have a coding manual or you're using some type of a mapping system, whether it is an online mapping system, if the mapping system is in your practice management software, that system should tell you how far out you need to take a code, meaning to which digit. Do you code it to the 3rd, 4th, 5th, 6th, or 7th digit? And for those of you, again, who may not have been on the call last week, ICD-10 codes now code out to up to 7 digits. It doesn't mean that you'll use all 7 digits every time. As a matter of fact, it's a fairly low percentage of codes that have to be coded out to the 7th digit. But you do need to know what the appropriate code is. And I'm going to be showing you some examples both from a coding book, and I'll be taking you to a coding website today to show you how to look up codes and how to know whether you should code out to whatever digit you're supposed to. You need to, if you're wanting to avoid non-specific codes, you'll want to avoid codes that end in a 0 or a 9. And that is unless it's appropriate. Sometimes it is appropriate to code a non-specific code. For instance, if you're still in a diagnostic phase and you haven't rendered a complete diagnosis or differential diagnosis, at that point you may need to just code a non-specific code. If you have a patient with back pain might be the most specific you can get until you actually perform your exam. So if you're just coding an x-ray, for example, for back pain in order to arrive at a more specific diagnosis, then that would be appropriate. But that would not be appropriate for a future plan of care. The other thing you need to know in your coding, number one, again, code to the highest level of specificity, which really was the same in ICD-9. It's just that we only had up to 5 digits to code out. Now we have 6 or 7, and we have laterality, whether in some cases we have to indicate right or left. In some cases we have to indicate what the pregnancy, what the time of the pregnancy is. In other words, what trimester a patient is in, or weeks of gestation. And I'll show that to you here in class today. The other thing you need to know is what we call your conventions. Now, the conventions equal rules. So those are your coding rules. And if you don't know, if you're not good at coding rules, it would be a good time to learn some of them. In ICD-10, the rules of the order of codes is much more specific than in ICD-9. So if you are a practitioner that utilizes multiple diagnosis codes, you're going to need to know, number one, what the order of those codes are. Number two, what codes can and cannot be coded together. And those are called the excludes 1 and the excludes 2 conventions. You'll also need to know your code also and code an order of code rules. In some cases, when you look up an ICD code, it's going to say code also origin of manifestation. And so you'll need to, at that point, you're being told that you need 2 diagnosis codes to adequately describe that patient's condition. And also, you will be given if you have a good coding manual or a good coding system, whether again it's online or with your practice management software, you will be instructed on the order of the codes, which code comes first, which comes second, and so on. You'll need to review any other new conventions that are present in ICD-10 that pertain to your particular medical specialty. If you have the AMA code, the conventions are broken out by chapters. So for chapter 20, which is illness and injury, illnesses and injuries as a result of accidents, there is a whole list of conventions that you'll have to follow for that particular chapter. And if you use those codes extensively, learn those conventions. That's very important. And that goes for the billers as well, because what we're doing as billers, and for those of you who are on this call it has a cross-section of Gold Star clients, which if you're on this call and you're a client of ours, I'm so happy you're on this call. By the way, it makes us very excited to know that you're taking the initiative to learn this. But the billers need to know as well, because one of the things that we do for you as a client of Gold Star is prior to billing out claims, we're looking at your diagnosis codes, the codes that you're using, and the billers are going to need to know whether you're billing in an incorrect order or not, and if that's the case, or if you're not coding to the highest level of specificity, we will not let those claims go out until they're fixed. We certainly, as billers, hate to touch claims more than one time. That's probably our biggest pet peeve. So our goal is to spend more time on the front end making sure that claims are going out correct and making sure that there are as few errors as possible so that we don't have to send a claim through and have it come back because it's a non-specific code or because it was denied because the codes were in the wrong order. So you as a practitioner need to know this, because we're not going to fix it for you. If you have codes that are in the wrong order, um, we'll spoil you, but only to a certain extent. And in the beginning, we may help you out, but if we see this as a recurring problem, then we're just going to kick those claims back to you and tell you to fix them. And then, once you have, then we'll go ahead and send them through. So make sure you know your coding conventions. And if you are using codes that require seventh digit, it's going to be important to know what phase of care you're treating that patient for that particular condition. Are you in the active or initial stages of care? Is this a subsequent stage of care? Or are you treating the patient for a sequela or for a late effect? And again, if you have any questions about any of the terminology that I'm using, feel free to either make a little chat message to me, and I'll try to answer all of those questions within the chat. And then also I'll be opening it up for questions in class. So let me see if I can get there we go. Let's look at some basic documentation rules. Coding and documentation go hand in hand. You really can't have one without the other. And so I always use the illustration of the IRS. Every year, we file a tax return, and we tell the IRS that we have made so much money, and we tell the IRS that we are taking these deductions as far as business expenses and personal expenses, and we deduct that amount off of our income, and then we arrive at what's called an adjusted gross income or a net income, and we pay taxes on that. And so when we send in our tax return to the IRS, most of the time it's going to go through and there won't be any questions, and the IRS will process that tax return whether we owe money or whether we get money back. We'll get a refund or we'll owe money. Insurance is the same way. We submit claims based on our coding to insurance carriers, and we're telling the insurance carrier, this is what we did, and this is why we did what we did. This is how much we charged. These were the extenuating circumstances behind this encounter. Maybe that's where our modifiers come in for our coding. And then we submit that to the insurance carrier. And then what happens is the insurance carrier, most of the time, will process those claims. Won't be a problem. However, occasionally, they're going to do the same thing that the IRS does. They're going to come back and send you a letter that says, prove it. Prove what you did. And the rule of thumb across the board is, if it's not in your documentation, it did not happen. I don't care if it happened or not, but if you didn't document it, it did not happen. So you have got to make sure that everything you put on a claim form, every coding item that we use on a claim form is backed up by your documentation. As billers, we won't know for sure if that's happening. Every once in a while, we might ask you for some chart notes just to spot check you to make sure that your documentation is where it should be. Right now, as we speak, we have made an offer out to all of our clients to do a much more comprehensive chart audit. I'm working in conjunction with Dr. Ron Short. Dr. Short is a speaker and presenter with the Chiro Code Institute. He is a CPC, certified professional coder. He's a chiropractic doctor. He teaches extensively with Chiro Code, but he also does medical coding and medical chart reviews. He's also a certified medical compliance specialist, as am I. And so Ron and I, what we are doing is making an offer to all of our Gold Star clients to do what's called a 3-chart review. In the 3-chart review, we take 3 of your charts, you send them to us, we go through them with a fine-tooth comb, and we will point out the deficiencies in your charting. so that you can be assured that your documentation is up to snuff from both a billing and a compliance standpoint. We're charging $250 for that, and that's basically covering my costs for Dr. Ron to help me out with this. He does it. You'll have a report prepared. It usually takes anywhere from 1 to 3 weeks, and of course, the more chart reviews we get, the longer it may take for you to get that back. But be assured that your chart reviews will come back by no later than the middle to end of August, and so if you get those to us soon, now if you don't have to do the chart reviews, but that is an availability to you, and if you do want to have a chart review conducted, then let me know in an email, and I'll send you the specifics on what needs to be done. Make sure, coming back now to your documentation, make sure that your documentation is legible. For those of you who are still handwriting notes, that's okay. There's nothing wrong with handwritten notes. However, your handwritten notes need to contain the same level of specificity that EHR needs to have. If your documentation is not legible, it didn't happen. If it can't be deciphered, it didn't happen. It's the same way as if it's not documented, okay? Your notes have to be signed to be considered a valid note. That is probably when I do documentation audits on doctors, that is the first thing that I look at, because I don't even have to be honest with you, and I'm going to tell you, insurance carriers are the same way. If they're auditing your documentation, the first thing they're going to look for is your signature. If it's not signed, it's not valid, period. I don't care how good of a note is, you have to sign it to make it a valid note. So make sure you're signing all of your SOAP notes, each one, each day, okay? Another thing is avoid cloning your notes. Even if you are a practitioner, and we do have chiropractors here on the line, I have a physical therapist, I have speech therapy here on the line, and OB. I have, a number of medical specialties where you treat patients for an extended period of time for the same diagnosis. The diagnosis code may not change, but your notes need to change. So you can't just copy paste the same note that you did 2 days ago or 2 weeks ago and use that as the exact same note. That is called cloning, and that's non-compliant. It's not a valid note. If an insurance carrier sees the same note over and over again, or they even see that maybe you changed up a few little words, they're going to be able to tell if you're cloning your notes. So be very careful. Another thing is avoid cloning diagnosis codes. We have some people, and chiropractors are notorious for this, physical therapists can be as well, of having their favorite set of diagnosis codes, and they use the same ones on every patient. And that's cloning diagnosis codes, and that's very dangerous, because what you're doing is you're basically taking some very non-specific diagnosis codes and applying them just so you can get a claim out, and that's a real big no-no, so be careful about that. If you're handwriting documents, or even if you are using an EHR program and you come up with your own little abbreviations that are not standard in the medical field, and standard abbreviations are the ones that I have listed here, like TX for treatment, DX for diagnosis, FX is fracture. Those are very standard, okay? But you may have ones that are your favorites that you use a little shorthand, and if that's the case, then you need to supply your carrier, if you're ever audited, with a legend of abbreviations, and make sure that all your documentation is consistent to those abbreviations. So use the same ones over and over again, okay? Now again, this is very basic stuff, but if we can get ourselves to the point where we're at least following this general criteria, I think most of us will improve our documentation by a lot just by following these basic rules. Okay, so let's go ahead. We're going to get right into the mapping of the codes now. So hopefully what you did, and I spoke to you last week about this, is gathering up your top 25 to 50 codes that you use in ICD-9. Okay. And then what we're going to do is I'm going to show you a few different ways to look your codes up, or type in keywords. I'm going to show you both a manual way to do it and an online way to do this. Okay. And from there, once you have your keywords within your code, then you will be directed to an area of your coding system, again, whether it's a book or an online format or your practice management software, okay? Any one of those will direct you to the appropriate code. Now, please understand that your mapping software will not give you all you need. It just won't. It's a starting point. And so what you need to do is make sure that when you have your codes mapped over, that you're still reviewing them for the highest level of specificity. The other thing that you need to do is go to the chapter or the search area, if you're doing this online, where your code set is, and make sure you look at the conventions and the coding rules, and also look for different levels of specificity. Look for the code also rules, which codes need to be coded together and which ones are not supposed to be coded together, which are your excludes codes. So you'll need to do a little bit more work. Once you have found the correct code set in ICD-10, you'll have to look at a few other things before you can determine if that is indeed the most specific code. The resources are numerous. I am today, when we're going through the how to look codes up, I'm actually going to be using you'll be seeing examples of the AMA ICD-10 book, which is found in the AMA book, from the AMA bookstore, and of course you can get it at a number of other places, but right now it's on sale for $79.95. And I'm also going to be showing you a website for converting ICD-10 codes. For those of you who are not paper folks, I like both of these very, very much. I'm a paper person. I love looking things up. I'm a good researcher. So I like looking things up in books. And I will tell you that as far as coding books, the AMA coding book is really, without a doubt, going to give you everything you need to code successfully. And once I show you how to do it, you'll understand what I'm talking about. The ICD-10 conversion website that I'm going to show you, and of course this is just one of many, but I've vetted this one as far as whether this will give you the highest level of specificity, and I'm very sure that it will. Again, if you're using the right words and the right terminology to get yourself to that point. So we'll be looking at both of these today. Other resources that you can be looking to for your ICD-10 coding and conversions are through CMS. They have some great resources, and I have here the different websites that you can go to within cms.gov. If you just go to cms.gov and click on the ICD-10 link under Medicare, it will take you to these 3 different sub-websites, and there are a number of others as well. The last one, the one that ends in 2016, ICD-10 CM and GEM. GEM stands for General Equivalence Mapping. This is actually a mapping tool within CMS that will allow you to map over your codes if they can be mapped. We also have some good industry-specific coding tools through the Cairo Code. If any of you listened to Dr. Mario Fucinari yesterday, he was on with Cairo Health USA teaching a 1-hour documentation and ICD-10 coding session. He has a little booklet called Top 100 Codes for the Chiropractic Profession. He's already mapped them out. You may want to look at that one. American Academy of Family Practice, American Behavioral Health and Wellness Association, the AMA, the American Chiropractic Association. I mean, there are a lot of really good resources for helping you map out and convert your ICD-9 to ICD-10 codes. Use literally whatever you're the most comfortable with, okay? And your practice management software is another ICD-10 resource for you. But I am giving you a disclaimer and a beware on that. Your software and any GEM or general equivalence mapping tools are only as good as the words you use to describe the condition. You still need to know your conventions, your order of coding, and so on. It's going to help you do the work. And I use this illustration. You know, a car is great, but it's not going to go anywhere unless you get behind the driver's wheel and turn it on and start pushing the pedal down. And the same thing goes for any mapping software you have. It will only take you so far before you have to get behind the wheel and finish the work with the level of specificity and coding that you need to do for ICD-10. Okay? All right. That's all I have on this actual presentation. We're going to actually get into now some more specifics. So the first place I'm going to take you here is, and again, these are from the AMA. If you go to the AMA coding book, and if you have one of the chapters that is in there is a chapter of coding conventions. Okay? And I just took what I did here is I took my book and I made some copies of some of the chapters and some of the pages so you could see how you need to look at this. Okay, so for example, you'll notice that as I said, this is the ICD-10 official guidelines for coding and reporting, okay? And it goes by chapter. So here, chapter 19 is injury, poisoning, and certain other consequences of external causes. And it gives you the 3-digit initial code that these coding guidelines pertain to, which is, as I explained last week, this is our family name, the family name of codes. And the S codes for are fractures, sprains, and strains that are a result of some type of an injury. Okay? The T codes deal with poisoning, overdosing, underdosing, accidental overdosing, intentional overdosing. All of that is in your T codes. So, you know, if you're a family practice doctor or if you're a mental health, a behavioral health practitioner, and you have somebody that is coming in with some type of let's say, mental health issue, and they're, you know, entering into a psychotic episode because they suddenly stop taking their Paxil, and you can't do that, you have to graduate off of it slowly, then you would actually code that as an accidental underdosing of medication. And so you would code the psychotic episode as a result of accidental underdosing. So, but these different chapters will give you some specific things you need to know about the chapter. And one of the things you're going to see in chapter 19 is the application of the 7th character. Most of the categories in chapter 19 have a 7th character requirement. I'm going to show you some examples here, okay? And it will tell you that and these are what we call the extensions. The extensions are the 7th character. and the extension is, the most common ones are going to be A, D, or S. And so the seventh character, A, means initial encounter, and this is the code to use if you're using an S code that requires a seventh extension. You'll need to know what phase of care you're in. So the initial encounter is used while the patient is receiving active treatment for the condition. Active treatment can be examples of surgical treatment, emergency department encounter, and evaluation and treatment by a new physician. And it can also be active care, for instance, if a patient is on a physical therapy plan of care for repair of a fracture, or reconditioning of a fractured knee, or they've had a complete hip replacement and they're under active care with a physical therapist. That diagnosis code will be used with an A, okay, throughout the care. It's not just the first time, okay. The initial encounter means the initial as long as they're receiving active treatment. The D is used for encounters after the patient has received active treatment and is receiving routine care for the condition. And here are some examples. It will give you a cast change, medication adjustment, aftercare, follow-up following treatment of an injury or condition. So that's when you would use the D as the subsequent encounter, and the S is the sequela for use of complications. And it gives you some important information on the sequela. So it says this gives you an example of what a sequela is. It's a late effect, meaning a scar formation after a burn. So the scars are the sequela or the late effect of the burn. When using the seventh character extension, then it tells you it's necessary to use both the injury code that precipitated the sequela and the code for the sequela itself. Okay, so it's telling you you have to use two codes. So these are the things that are important for you to understand when you're coding out of a specific chapter of the ICD-10 coding book. Okay, and if you're coding fractures, it gives you even more specific guidelines. It gives you guidelines for complications of cervical treatment, for fracture repairs, and so on and so forth. And of course, in this small time we have, we only have an hour here. We're not going to have time to go into all of the specifics of your particular medical discipline. However, we would be available to do more specific industry coding with you if you need us to do that on an individual or a bi-clinic basis. So just be aware that, and this is one of those pages. Here's a second page on the convention. This gives you some definitions. So for instance, you have one of the things you're going to see very commonly is this excludes one and excludes two. This is very important for you to know, and this is anybody that does ICD-10 coding. This correlates across all of the chapters in ICD-10. And exclude, if you see a code and underneath that code it says excludes one and then it gives you a set of codes, that means that you can never code with the other code. They can never be coded together. Okay, so and I will show you some examples of excludes one. Excludes two means that it's not included with the diagnosis that you're using, but it means that you can have both conditions at the same time, and it may be acceptable to use both codes and the excluded code together if supported by the medical documentation. So some of these definitions are important for you to know. And again, all of this is found in the AMA book. If you have an industry-specific book, you will probably have these definitions as well. For instance, ChiroCode might have these at the front of their book. So learn them and know them. Know what those coding rules are. Okay, I have to turn this one around because of my scanner. These are your code also rules. So for instance, um, your if the code itself, when you look it up, says code first, and it gives you a list of codes, then that means you would have to code that code first and then the code that you're choosing second. So these instructional notes will be found, at least in the AMA book, in red type and provide sequencing instruction. This is really important for those of you who utilize multiple diagnosis codes to describe patient encounters. Okay, and code also means if you may see that as an alert next to a particular code, it may say code also. A code also note alerts you that more than one code may be required to fully describe the condition. And at that point, the code sequencing is discretionary. It doesn't mean that it needs to be in any particular order, but you should code these two codes together. Okay? So again, it's impossible to go through all of these conventions, but I'm just touching on the most important ones for the medical disciplines that I know are represented here on this call today. Let's take a look and let's get a little bit more specific. So I want to go to, actually, let me get to my desktop and I'm going to show you how to look up a code. Let's see if this is the right one. Nope, it's the same one. In your book, in each of your books, you're going to have a set of keywords. Okay, and for example, in the coding book for AMA, the first thing you're going to want to do is you're going to want to look up a keyword. And I'm going to use the sprain strain code in chiropractic as an example. So if you look up, and I thought I had this, but I guess not. I went into the, oh, there it is, alpha index. So the first place you're going to go to in your book is you're going to go to the alphabetical index because you don't know what the code is, you know what the word is. And if that's the case, then what you're going to do is you're going to look up the word sprain. So I need to try to find the code for a cervical sprain. So I look up code, and the first thing I'm going to do then is after that I go alphabetically, and I'm going to go to the spine. And what I see here is I have the spine, strain on the spine, cervical, lumbar, and thoracic. And then next to it, I see a check mark. Now this is the code for a cervical sprain, S13.4. However, there's a check mark next to it. And anytime in the AMA book or in your online resources, if it says sometimes it will give you a check mark, sometimes it will give you a number that will say this is the extension that you need to code out to, or the level of specificity. So in other words, I'm looking this up in the alphabetical index. This is giving me the general information of a cervical sprain, S13.4, but I have a check mark, which means that I have to code to, this is not adequate for coding for billing, so I cannot use this. It means I have a more specific code that I have to go to. So from there, I'm going to go to the actual page that contains the S13.14. You'll see it right here. And this gives me the cervical, it says subluxation and dislocation of cervical vertebra. Okay, so the S13.14 is telling me that I have, number one, I have, I'm sorry, S13.4, here we go. Sprain of ligaments of cervical spine is the one that it directed me to. But see what it's telling me over here? I had that check mark. Now it's telling me I have to go out to the 7th digit. My question to you is, if I have a diagnosis code that is 4-digit, how do I get it out to the 7th digit? And I do that by use of the placeholders. And we talked about this in our class last week, was the X placeholder in the 5th and 6th digits. So in this case, if I am coding a cervical sprain and I have to code out to the 7th digit, and if you go to the S13, the beginning of S13 has some of the coding rules. So I come down here, and here's S13, and everything under S13 has some general coding rules. It tells you what types of sprains are included in the S13 category. It tells you to code also any associated open wound if applicable, okay? And it tells you that we have an excludes 2 for strain of muscle or tendon at the neck area, meaning that we can code the S13.4 along with, because this is the ligament of the cervical spine, and S on the excludes 2, S16.1 is the muscle or tendon around the cervical spine. So you can see how specific we're getting now. That old 847.1 is not going to fly anymore. You know, the cervical sprain, strain. Now sprains and strains are totally separate, and it's going to ask you, is this a sprain of a ligament joint, or is this a sprain of a muscle tendon, or strain of a muscle tendon? So we have to know the difference. And it's telling us on the S13.4 we have to code out to the 7th digit. So what that means is we have to, the 7th digit is going to be the A, D, or S, initial encounter, subsequent, or sequelae. So if we're coding S13.4 and we know we have to code it to the 7th digit, and we're coding, let's say, during an active stage of physical therapy or chiropractic care, then we're coding S13.4XXA. Hopefully that makes sense to everybody, because you would not put the A on immediately after the 4, because what does that do? That creates a 5-digit code. They're saying they want a 7-digit code, which means we need the placeholders to bring that out to the 7th digit and put the extension on the 7th digit. And it tells you it needs to be the 7th character. Okay? So, in a nutshell, when you're looking up your codes in a coding book, your coding book should be telling you how far out the code needs to go, what areas or regions of the spine this would include. And again, for those of you who do personal injury claims, this is your whiplash code. But it has to be coded out to the 7th digit. You're not going to be able to just put in 13.4. That will get rejected and it will get kicked back. So you'll need to know, and you'll need to describe to the insurance carrier whether we're dealing with an accident. Let's move on to a couple of other coding examples. Let's look at hypertension for those of us who do hypertension. So if I went and looked up, oh, sorry, wrong hypertension one. Let's look at hypertension. Okay, here are your hypertension diseases. And we have some family practice doctors and some urgent care doctors here on the phone today. So, or on the call. So, essential primary hypertension includes high blood pressure. Yay, it's a 3-digit code. And that's great. And in some cases, that's enough, just that 3-digit code, and it tells you what it includes. However, there are exclude ones. So there is an exclusion for hypertensive disease complicating pregnancy, childbirth, and the puerperium. So if you're coding hypertension, but you're coding hypertension on a pregnant woman, then you're having to go to the O codes, the OB codes for that. Okay? And if, however, there is an excludes too, that essential primary hypertension involving vessels of the brain, that can be coded along with essential primary hypertension. And this particular code does not tell us, there's nothing next to it, which means it does not have to be coded out any farther than the 3-digit code. However, if the hypertension is a secondary hypertension, not primary, meaning secondary to another procedure, you have I-15, but this will tell you that you have to be more specific, that your you need to know what it's related to, other renal disorders, to endocrine disorders, and so on and so forth. So you just need to, the main thing that you need to do, again, is you look through these codes and look for those diseases that you routinely treat, so you'll know, number one, how far out you need to go, what your includes and excludes are, and any other pertinent information you need to know to successfully code that. Let's take a look at just a couple of other musculoskeletal codes we'll look at. Your scoliosis codes have really gone out quite a bit as far as been expanded. So we have under here, we have scoliosis starting at M41. Now if you go and if you type in your keyword scoliosis, you would get this code, M41, scoliosis. However, it's not taking you out far enough. And it's telling you that you need to go out to the 4th digit, all right? So let's go find the 4th digit. It could be M41.0, M41.91, it could be M41.2, other idiopathic scoliosis. It's not a juvenile scoliosis. But now look, you come to this one and it says 5th, which means there's an even more specific code. Now you have to take the scoliosis to the region of the spine. Unspecified cervical, cervicothoracic, thoracic, thoracolumbar, lumbar, and lumbosacral. So you'll have to know what regions of the spine are affected, and if you have a scoliosis that affects both the cervical and the thoracic, you will choose cervicothoracic. You won't choose cervical and then choose thoracic. You'll choose the one in the middle that involves both regions. Another one that we can look at is on the spondylosis is the same thing. When you look at spondylosis, it takes you to the 5th digit. However, from there, you have how far out can you go. It's going to tell you you're going to have to go out to at least the 6th digit, because it's going to ask you with or without myelopathy or radiculopathy. It's going to want to know the region of the spine. So you will need to make sure that you have all of these mapped out for the different regions of the spine. Okay? Or have a good mapping book such as the AMA book or the ICD10. Let's take a look very quickly. I'm going to show you how to do this online. using the ICD-10 data. Now, this is a free website. It's a very good one. But again, it's only going to be as good as your words that you use. And so here's what you would do. If you need to look up a code, you would go into the search. You would pull up your ICD10data.com website, pull up your search, and just type in hypertension. And then you would search. And this takes you to right now, the ICD-9 code for hypertension, which is 401.9. And then right here it says convert to ICD-10. So you click on that, and then it tells you ICD-9 401.9 converts approximately to ICD-10 CMI10. And if you click on that, it gives you a lot more information. So it will tell you, number one, that this is a billable code that can be used to indicate a diagnosis. It will give you the clinical information as to what validates this code. So in your documentation would need to consider using some of this clinical information as proof that this code is medically necessary. And it would give you some synonyms that you could use to describe this condition. It gives you your excludes 1 and excludes 2 codes. It gives you your includes, what would it be included within that code, and it gives you a few coding rules that you need to know. So this is a good one. ICD-10 I10 is not usually sufficient justification for admission to an acute care hospital when used as a principal diagnosis. So if you're an urgent care clinic and you have to send a patient over to acute care, then you're going to have a lot more than benign essential hypertension as a reason. Hopefully this is making a lot more sense to everybody now. And I know I'm going very quickly because we do have a limited amount of time. Here's another search that I did. I did a search for torticollis, and it gave me 31 results across 3 classification sets. So if we look at just torticollis in general, it's the M43.6, which is the ICD-10 code. And if I click on that, it tells me that M43.6 is a billable code. Okay. It gives me, again, my excludes, and it gives me my includes. So it will give you a lot more, and that this is a symptom, it's not a disease, and sometimes you're going to be diagnosing signs and symptoms. So this just gives you a good example of how to use your mapping software. Now what I'm going to do is I am going to open us up. I'm unmuting everybody, hopefully. Let's see. Unmute. No, unmute. How do I do this? Unmute. Okay. Everybody is unmuted now. So let's see. Number one, I'm going to open my chat window to see if I have any questions that have been chatting. We're good. We're good. Okay. All right. Does anybody have any questions on this? Are there any particular codes that you'd like to look up? Ida had one. She wanted to look up 719.50, which is decreased range of motion. So I'm going to go here, and in this ICD-10 data, I'm going to just type in 719.50. And here is your ICD-9 code, 719.50, convert to ICD-10. And it's telling you that the code that it maps over to right now is stiffness of unspecified joint, not elsewhere classified. What is that unspecified code probably going to do? It's probably going to reject, okay? However, it is a billable code, and it does tell you it can be billed. However, beware, because if you use the M25.60, then you're going to probably have some issues if you would want to describe a joint, a specific joint. So that's not, in other words, again, this is an unspecified code. It ends in a 0 or a 9, and you can have some issues with that. Okay. Was there another question? Let's look at M20 to M25. So if you pull up M25, now you have the big expansion of codes of the different types of joints. And again, if you use the words elbow pain, pain in joint, pain in an unspecified joint ends in 0, pain in shoulder, pain in, but here's what happens. The pain in shoulder, this is it says it's a non-specific code. It's got a red arrow. And that means that there is one that has greater detail, and that is your laterality. That takes you out to your 6th digit. You have right shoulder, left shoulder, unspecified ends in 9. Okay, so yeah, you can use it, but again, if you just use pain in joint and you don't take it out to the specific joint that you're dealing with, then you're going to find that that code may be she said problem is she can't find the neck. So we would have to look at, again, taking that code and then look for pain in neck. Who can give me, again, I'm not a doctor, so a doctor that's out there, please call out a joint associated with the neck. Can somebody give me one?
356.
I'm sorry? No, what's
The
the
fifth
word? What's the word for the joint?
cervical.
No,
The,
not
the, the
cervical.
cervical region.
What's the actual joint
Oh,
that would be
a
associated
facet joint.
with what?
Facet joint.
Facet, okay. Pain in facet pain. So now you have M53, which is your code, and here's how you've got all different codes that, here's M53.82. So again, with your own mapping software, you would have to look, know the words. So neck pain or joint pain is not going to be good enough. It needs to be pain. You need to know what the neck joint would be called, and or any other, or if You're just going to need to know more words and have a much better handle of medical terminology than you did before if you're doing the coding. Okay?
Can you clarify? I have a question.
Yes.
Can you Can you clarify for, typical treatment plans for chiropractors where they have an acute episode and you're putting them on a plan for 3 weeks, for example, that extension seventh digit, is that whole treatment period going to be an A for the extension, or do you have to switch it after the first visit?
Well, remember that the only time you're going to be using a code for you're going to need that seventh digit is if you're treating an injury. So this is going to apply mainly to personal injury. Okay, if you're treating a patient for a condition that is not injury related, that doesn't require the seventh digit extension, then you don't need to code the seventh digit at all. However, your question is that if they're under active treatment, you put them on a treatment plan, and you've established a reevaluation at the 12th visit. For that first through 12th visit, you'll use the A. Yes.
For the 12th visit, you'd use what?
Up through the 12th visit, you would code that with the A extension if it is in a strain code as a result of an injury.
Okay.
Okay.
So then after their reevaluation, if they're determined to need continued care, would you change the A, or, I mean,
No, no. If they need further active treatment, if they're not
okay,
resolved, then yes. However, if let's say you release them from care and then you schedule them for a follow up in 2 weeks, then that's when you would change it to the D.
okay.
All right. Now, this does bring up a good point, and I know some of you may are not chiropractors on here, but since I do have enough chiropractors on the call, I need to address this. It's important. Some of you like to mix up your injury and illness codes in ICD-9. I see very commonly 729.1 and 847.0 on the same encounter. Okay? And in ICD-9, we've gotten away with it, but in ICD-10, you're not. If you are going to use an S code, which is any code that starts with the letter S, and remember S equals sprain strain, for those of you, just to keep it simple, S equals injury. So if you're going to use a cervical strain, you better have an injury documented. If you don't use the code, because it will flag those claims to go. What will happen is, and you'll send that out to the insurance carrier using, let's say you send it to Blue Cross using an S code. As soon as Blue Cross sees an S code, they're going to kick it back saying this should be billed by your auto carrier. Or if they'll kick it back saying we need the nature and time and date of the injury, of the actual injury, because on the claim form, there is a place on the claim form to indicate whether an injury actually took place. It says auto, work, or other. That's box 10, I believe, on the claim form. And if you don't have that checked, but you put an injury code in there, it's going to kick it back in ICD-10. So please be careful about that.
So if someone has an injury at home, they fall down the stairs, you need to check that box that they had an injury at
If
home?
you use an S code, yes.
Yeah, okay.
And it's called other, because it gives you some choices. It gives you auto, work, and other. And if you do that, then you're going to have to add your E code, or your E code, which is your external cause. There's a whole list, and there will be a code that says fell at home in kitchen, and you're going to use that code to correlate to it.
You get it. Oh, it's Gail.
Okay. All right. Well, I'm going to end the call. I do have some of my billers on, and I do have to go through a short billing meeting with them. Next week, we'll continue this, talking more about the transition and making sure that everyone is where they
Here,
need to
call
be
her.
as far as,
Get on there and call her.
I'm sorry, as far as transitioning over to the ICD-10 code for the office.